All right, so today we're going to begin by talking about neurogenic disorders of speech and language. We're going to kind of blow through the first couple of pages because it's not really vitally important, but it's good to know. Over on the right-hand side of 1098, it says the use of speech for communication contributes to our identity as a human being. As a result of disruptions, the ability to communicate, whether caused by structural abnormalities, neurological condition, or non-organic, may affect a person's daily life in important ways. So I saw this firsthand. My grandmother lost her abilities to speak. She was diagnosed with severe COPD and lost her abilities to communicate. They could not give her a speaking valve. So she literally spent about the last year of her life being inarticulate to speak. And so it's very difficult for her. So you'll have patients who are like that. They are on ventilators and they won't be able to speak or produce speech because of the ventilator. And so you're having to make out what they're saying. So they'll try to whisper or you're trying to make it out. They can use communication boards to help. Speech language pathology helps with those. Or they can write things down, or sometimes family members can understand gestures, and that kind of helps. But you're always looking for ways to communicate with people. Over on 1099 says the term communication encompasses all behaviors that human beings use to perceive and transmit information. Language is the quasi-automatic behavior of selecting vocabulary and sentences before communicating a message. Over on the right-hand side, kind of in the middle, it says 37.5 million American adults have a hearing loss issue, and that affects their abilities to produce speech. So without hearing, you can't produce speech. And this is primarily used speech language pathology, but we still are required to have some understanding. And there are some things that we need to understand about speech problems as well. So a lot of the treatment aspects is done by speech language pathology. A lot of the how to deal with these patients from a therapeutic standpoint is what we will do. So there's not a lot of PT intervention for these, but there will be a lot of knowledge-based understanding that will help you grow in your skill sets to treat these patients. So, organizing language, it says when an individual generates an idea they want to express, it's transformed into words and sentences by calling into play physiological and acoustic events. And then that turns the message into a linguistic form. And that's what our objective is when we're talking. Phonology is the study of sound systems of language. Words make up the lexicon or the vocabulary that we use. English, the language, is comprised of 16 vowels, 22 consonants, which are combined into larger units called syllables. So that makes sense. The grammar or syntax of language determines the sequence of words and are they an acceptable formation of sentences. So when you're documenting patients who have difficulties with this, like certain types of aphasia, you'll talk about the syntax of their language. So their language will lack syntax, sequence of words. Are they acceptable in the right format? It says the language system, the last sentence there, that refers to the meaning of words is called semantics. So we're talking about the semantics of language. Sometimes there's semantics involved. So dealing with the meaning of words. They are, so you'll have some patients who have strokes and they become very much so concrete thinkers, like they can't abstract think. You may be joking with them, trying to laugh and joking. You're talking to one of your coworkers. You go, man, get out of here, go fly a kite. And they'll go, well, it's not windy outside. You can't fly a kite. So they miss the semantics. They don't see the joke side of that. They only see the technical terminology. So they have poor semantics. Okay. So speech production. That's where we want to go. So the speech organs consist of the lungs, the trachea, and the larynx. So when you're looking here, we have lungs going up from the lungs. You have the trachea going up from the trachea. You will have the larynx and the pharynx, the nose, and then the mouth. When considered together, they comprise a tube referred to as the vocal tract, which extends from the lungs all the way to the lips. Moving the tongues, lips, and other parts varies its configuration. So that's how we produce sounds and language terminology. Our vowels, our A, E, I, O, U, and sometimes Y. So when you were in kindergarten or preschool or first grade, they taught you how to move your mouth to produce certain sounds, because the articulation of that sound and the clarity of it was due to being able to use your speech organs appropriately. It says the shape of the vocal tract acts to modify the aerodynamic qualities of the airstream during speech. That's what the video was showing, how we have to produce that airstream. Primary function of the vocal organs relates to basic life-sustaining functions such as breathing and swallowing. So that's the first thing that's most important. So we need the lungs for gas exchange, exchanging O2 for CO2 so that we can survive. And then also swallowing, being able to ingest. So all of this passes through different components. Passes through some of the same components, passes through the mouth, the larynx, and then the larynx, the pharynx, and then it decides where it needs to go. If it's air, it's going into the trachea. If it's food or water, it's going into the esophagus. So, and there's a glottis there that helps to seal off everything to make sure stuff goes where it should go. And that's what that thing was showing you, that video. So when you're looking here, if it's air, it's going to pass through it easily. So air passes through it easily. Your body can detect air, but when it's solids like food or things like that, then there's a cover that goes over the glottis, and it pushes. The cover goes over the glottis. No, so let me say that right. So if it's air, it's going to pass through the epiglottis and go into the trachea. If it's not, then it's going to go into the esophagus. So, and the glottis and the epiglottis is what helps to control that. Okay. It says, yeah, these organs not only take different roles for speech, but they also function differently when engaged. A full cycle of inhalation and exhalation takes about 5 seconds. So breathing in, breathing out, it's about 5 seconds. When speaking, we control breathing according to the demands of the words and the sentences we're producing, sometimes reducing the rate of breathing to as little as 15% of that devoted to inhalation. So the longer your sentences, the more you're devoting to closing off that trachea from and shedding off lung transfer of air so that you can complete the sentence. So you ever hear these people that can talk really, really long sentences, or some rappers now can just seem like they just go on forever, or some folks, old songs, they hold notes and you're like, ooh, God, how are they holding the note that long? And you're like, God, how are they doing that? It's incredible. So that's what that's talking about. It says, the steady stream of air exhaled from the lung is the source of speech production, which is made audible by rapid vibrations of the vocal cords. So you vibrate the vocal cords, that's how we get speech production. During speech, we alter the shape of the vocal tract continuously by moving the tongues, the lips, and other part of the system. By moving the tract, we modify the acoustic properties. We're able to produce different sounds. By altering the tract during phonation, we transform the air into a resonance chamber. So we're able to make it do what we want to do, change the text, the picture, the tone, all of that of our voice. The larynx itself, so let's go back up here. So when you're looking, so this is coming from the neck, so the hyoid is at the level like C2, C3. So coming down, so you're behind that. The larynx acts as a barrier to prevent food from entering the trachea and the lungs by closing the vocal cords automatically during swallowing, which is also helped by the action of the epiglottis. So the larynx helps with that, and then the epiglottis also helps with that. By opening, the larynx is not a fixed, rigid organ, but because of its cartilaginous construction and connecting muscles and ligament, it moves up and down during both swallowing and speaking. So you can see how vital it is. Then we have the vocal cords. They create the sound of speech and are located on either side of the larynx. So you have these vocal folds on the side of the larynx. And it's located right near the Adam's apple, which is at the level of C4, C5. So if you're looking at the cervical spine, around the level of C4, C5 is where your vocal cords are going to be. Okay. The pharynx is the area of the vocal tract connecting the larynx to the nose and mouth. So we're now coming up the system. So now we're coming up into the pharynx. It says the most adjustable components of the vocal tract is the mouth, whose shape and size can be modified more than any other organ of the oral motor system. As far as you want to go with that. The term articulation refers to articulating, I hate defining the word with the word, meeting of the various organs of the oropharyngeal cavity to produce sound and speech. So I'm trying to articulate or speak. So you can write in a patient's chart they have poor articulation due to such and such diagnosis. They can't speak well. So that's about, again, I don't want to go crazy on this because we're not speech theory. Okay, so that leads us to aphasia. Aphasia. So, aphasia, it is an acquired language disorder. Usually it's going to affect the left hemisphere or the dominant hemisphere. The book didn't give you this information, so that's why I put this in red. So if it's in red, that means the book didn't give it good clarity. So, language disorder, left hemisphere primarily. And the reason why it's primarily seen in the left hemisphere is because more people are right hand dominant. So it's going to be hand dominant specific. So that's the number one thing I want to say about that is hand dominant specific. So if you're right-handed and you have a left brain injury, you're probably going to have some type of aphasia if you're affecting those areas where it can be affected. If you're left-handed and you have a right brain stroke, then you will also have speech language deficits because that's housed on the right side of the brain primarily. So it is hand dominant. I know that sounds crazy, but it really is. They've done studies. So usually it's left hemisphere, mostly from some type of left middle cerebral artery stroke. And it can affect all of the different aspects of communication that we think about. Comprehension, expression, which is communication, reading and writing could all be affected based on what's going on with the patient. Okay. The book does tell us under classification of nomenclature, aphasia, again, it talks about what we just talked about. It says in acquired aphasia, the CNS or trauma compromises structures in a focal rather than generalized fashion. So we're going to affect specific areas of the brain. Over on the right, it says the characteristics of speech production provides the basis for determining aphasia classification. Speech output characterized by hesitant, awkward, interrupted, inaccurate production of speech is called non-fluent because it's broken. So when you think about it, when you think about fluency, you want to think about going through smoothly without interruption. Smooth without interruption. How many of you grew up as a kid and you went to a class where they made you read out loud? Anybody remember reading out loud in school? And so the teacher would call on some people and you could read well and you cheer, the teacher go, "Great, Kenny, you are a great reader." And they called on little Johnny, and little Johnny was like, "And the cat did not move." And you like, "Freaking Johnny, I just want to choke you." What's missing from Johnny's speech is fluency. They're just chopping it up. It's not consistent. It's not fluent. So when you're thinking of non-fluent aphasia, it's the same way. It's like Johnny trying to read and he can't put all the words together contextually. So that's non-fluent aphasia. It says this contrasts with fluent, which the speech is fluent. It's just like, it sounds like they're reading off a script, but the words just won't make sense. So they're going to have almost a normal speech pattern. It's actually going to be a little bit faster, but the words won't make sense. So let's dive in. Fluent aphasia. So the slide is kind of a synopsis of things that are good to know. It's a synopsis of table 28.2, which I do want you to know those specific things that are listed there for the three. We only deal with Wernicke's, Broca's, global, and conduction. So we don't deal with all of these, but it is kind of a summary of all of these. So it says it's characterized by impaired auditory comprehension. So they don't understand. So when they reply back without understanding. That's why their reply doesn't make sense, because they didn't understand you on the front end. It would almost be as if I told you to take your fingers, stick them in both of your ears, and close your ears off as much as you could, and then I asked you a series of 5 questions, and then you undid your ear, and I said, respond to what I just said. Could you do that? So whatever you say won't make sense because you didn't even hear the question well. Make sense? So that's what's happening with fluent aphasia. They're not comprehending the question. And so it would almost be as if Carly speaks dual languages. It would be like Carly asking me a question in Spanish, and I have no clue what she's saying. And I respond back to her, "Yeah, man, it's a good day, I'm sure. All right, hope it went well. Yeah. Sí. ¿Dónde está?" She's going to look at me like I'm a psychopath because I don't comprehend what she's asking. So that's the concept. That's what Wernicke's is. It's lack of comprehension. They don't understand what you're saying, so what they say back won't make sense. Now, the important part is when you're dealing with these patients who have this, don't repeat back what they said to you because they're going to think you're a psychopath. So if they go, "Yeah, house, car, jump, yeah, road down the way and went, yeah, you did what I was supposed to do. And that's not answering the question. Don't you go, yeah, you jumped horse down the path, did what you were supposed to do. They're going to look at you like freaking crazy. So don't do that. I've seen that done. Don't do that. We'll show you how to deal with these patients. I have slides on that the book doesn't cover. But don't do that. That's the number one thing I want to tell you never to do. Okay. So it says, when it's severe, words and sound substitutions may be of such magnitude and frequency that speech is rendered meaningless. It seems like you won't make any sense. Patients with this tend to have the greatest difficulty retrieving the words that are substantive. So they don't know how to figure out how to say things that make sense. So they just put together a bunch of random words that are nonsensical. And those are called neologisms. So neologisms. A bunch of random words that just don't make sense. There are several types of fluent aphasia, but the most common one and the only one that I'm caring about is Wernicke's aphasia. So we call it either fluent aphasia, Wernicke's aphasia, or receptive aphasia. Again, it's usually going to affect the temporal lobe. So that's what you're seeing there on figure 28.5. It's going to be down near the temporal lobe. And it's on the dominant side. It's going to be on the side opposite. Usually it's on the left side, because if you're right hand dominant. Okay. It says it's characterized by impaired auditory comprehension with fluent articulated speech marked by word substitutions that don't make sense. Reading and writing are also severely impaired. So they're going to read and write the same as if they were speaking. It won't make sense. So that's what you'll see there in table 28.2. So the speech is fluent, but their comprehension, repetition, naming, reading and writing are all poor. So everything where they're having to reply back is going to be poor because they can't comprehend information. It says, although production of speech is generally intelligible, patients may reverse words and syllables or submit nonsensical words, and they produce what's called neologisms. Okay, speech output may be well articulated, yet surprisingly vague and irrelevant. That's what you're going to get with these patients. And most of the time, they're going to be happy and unconcerned. They don't even know. And also, because it's in the temporal lobe, they're rarely going to be physically disabled because it's nowhere near the motor center. So it's not going to be affecting the primary motor cortex. So usually if they have this, it's not going to affect motor. Okay. So that's fluent aphasia. Non-fluent aphasia is going to be dealing more with the frontal lobe, so it could affect sensory and some other things. But it's limited vocabulary, slow, hesitant speech, awkward articulations, and restricted grammar. So they're not going to know what words to say. And it's going to be choppy, like Little Jimmy, or whatever the fellow name is we talked about earlier. Just like you're chopping up words, not knowing how or what to say. It's going to be very choppy. Patients with this tend to express themselves in a vocabulary that is substantive and lacks the ability to retrieve fewer substantive parts of speech. So they'll just use basic nouns and verbs, but they can't connect it with prepositions, conjunctions, and pronouns. So you need all of those to make sentences work. So they're not going to speak in complete sentences. They're just replying with simple replies. Patients with this tend to have awareness of their deficits and usually have impaired motor function on the right side of their body. So they're going to have some motor deficits with this. Okay. Broca's aphasia is the most common type of non-fluent or expressive aphasia. And then under 28.2 there, you can see kind of what they're saying about it. Again, this just kind of all goes in slow labored effort speech. It's telegraphic, meaning it's going to be short phrases, just nouns and verbs. They will have good auditory comprehension, but poor repetitions because they can't find the words and know how to repeat. Writing is going to be impaired as well, so also their reading comprehension is actually relatively good. They can read, they just don't know how to reply about what they read. So that's where it's really a big difference from Wernicke's. Naming is poor, but it's because they can't access the names. Repetition is going to be poor again. Writing is going to be impaired as well. And then that right side hemiparesis. And they may also have apraxia, which we talked about last time, which is motor planning. Ideational or ideal motor apraxia. We talked about that in the last lecture. In the last lecture when we dealt with that. So that's non-fluent aphasia. Then we have something called conduction aphasia. Conduction aphasia. So you can look at the chart. The book doesn't cover it, but we will. So conduction aphasia is going to be a lesion of the arcuate fascicularis, or I don't know how to say that myself. Arcuate fasciculus? Yeah, we'll call it arcuate fasciculus. And it's going to be the connection space between Broca's and Wernicke's area. So it's this line here, the connection between Broca's and Wernicke's area. They have damage to that area, and that produces a conduction aphasia. And so they'll have good comprehension, and then poor repetition, naming, and writing. Their reading could fluctuate. So it doesn't have very good information, but it's called conduction aphasia. They'll have fluent speech but poor repetition. This is the big thing. Fluent speech but poor repetition. Fluent speech, good comprehension, poor repetition. So that's how it's separate from Wernicke's and Broca. Broca's has non-fluent speech, good comprehension. Wernicke's has fluent speech, poor comprehension. This one has fluent speech, poor comprehension. Fluent speech, good comprehension, poor repetition. Yeah, that's your biggest thing. Okay, and then global aphasia is the last one. It's dysfunction across all of these. It's not a type of aphasia, but rather a designation of severity. They generally have extensive damage, which may be anywhere in the left hemisphere. Sometimes it could be bilateral. They're going to have deficits with everything. So it's going to be like combining Broca's, Wernicke's, and conduction aphasia all in one. So everything is poor for global. Okay. All right. So needs. So aphasia recovery, we'll do a couple of those, and then we'll jump to treatment. Now, we'll warn you, treatment, what's on here is not in the book. It's comes from more detailed information that's going to really help. So, aphasia recovery says once it's persisted for years, a complete return to premorbid status is usually the exception, not the rule. So if they've had aphasia for years, it's probably something that they will continue to have. It's hard to recover. Language gains take place earlier as well as later, but usually it's much harder for later. They will need speech therapy. Down at the bottom, both type and severity of aphasia appear to carry predictive values, with global having the poorest prognosis. Basso reported that when patients with fluent and non-fluent of the same severity were compared, there was no difference in the degree of recovery. So people can recover. They did 881 consecutive stroke admissions to a community-based hospital. It was possible to make a valid prognosis within 1 to 4 weeks after stroke, depending on the severity. So you can start to look at these and see kind of how they're usually going to progress. So treatment. So basic strategies for all aphasias. This is for us. Remember, we don't treat aphasia. Again, we don't treat aphasia. We are not that people that's outside of our skill set, outside of our wheelhouse, that's outside of our scope of practice. So if a patient, family member is asking you, why are you not addressing their speech? That's outside of our scope of practice. It's not what we do. Speech therapy will work diligently with that, and we'll work in conjunction with them to help you. That's your reply. It's outside of your scope of practice. But what can we do to help these patients? That's what's important. One, use short, simple commands. The longer the sentence, the harder comprehension becomes. So early on, very short, simple things, yes or no type things, is going to help. Visual cues, gestures, and demonstrations are your greatest friend. Show them more than tell them. Speak slowly and clearly, makes sense. Allow extra time for them to respond, makes sense. Reduce background noise to make sure that they hear you clearly. And then confirm understanding through repetition or demonstration. And you already know for some, repetition is going to be hard. So you're going to have to demonstrate repeatedly where you're doing types of almost rhythmic initiation, where you're doing repeated things to help them to produce repetition. So hands-on, repeated repetitions so that they can get rhythmic initiation type ideas. Think about it like that. Yeah, if complete recovery is usually pretty early on. So, non-fluent aphasia, things that we can do. Again, encouraging them to express things. So early on in the acute care setting, yes or no type questions so that they won't get frustrated and shut down with therapy. If you're working in subacute, like a skilled nursing facility, you're working in a rehab, now you want to start to advance your questions so that they can start to learn how to answer those. So encourage those expressive attempts. Use cueing, where you use first sound of something, you show them, a walker, what is this? Walk, yeah, and so now they get it, walker. Visual cues are good. Gestures, picture boards, things like that. Avoid pressure or rushing them, that makes sense. Fill in the blanks usually help as they progress even further. If you're seeing them in outpatient, you can use a lot of fill in the blank stuff. And again, pictograms are always great. Visual boards, things like that, that helps. Wernicke's work on as their progression, improving comprehension, making sure they are understanding. So you're asking questions that are easier to comprehend, and then you can lead them into the right answer. Concrete language. Remember, they are going to have difficulty with language that's not concrete. They're going to see everything in very concrete terms. Demonstrations as well, nonverbal communications. Short direct commands very early on, environmental cues, always check understanding frequently to see what they understand, what are they gaining. So every day that a person is alive, they're going to gain more knowledge, and so their comprehension should slowly start to show you some evidence. So those are things that we do for aphasia from a therapy-induced thing. In recent years, down on the bottom of 1109, it says a form of language therapy that has been showing promise is a constraint-induced language therapy. So we talked about constraint-induced movement therapy, but they do a constraint-induced aphasia therapy. So that's pretty cool. I've not seen that before, but that would be cool if you get a chance to see it. Now you know that it exists. All right. Next, we're jumping to dysarthria. Yeah. So dysarthria, that's a good place to take 5. Take 5, we'll come back and hit dysarthria. And then dysphagia. Yeah. 5. Yeah. We can push through it if y'all want.
I thought we got out at 12.
Yeah, we might. It'd be 12-ish. We're close.
Let's just go.
Push through. All right, here we go. Dysarthria is motor speech. So aphasia is a problem with an injury to the brain, and it's affecting how I am able to produce language. Am I finding the right words? Do I comprehend? Dysarthria, they have the right words and they comprehend. They just have trouble articulating. So they don't speak well. It's kind of like what I call the music y'all listen to now, mumble rap. I don't understand a dead blasted word they're saying. Hey, like that's not even words. You're just mumbling. Mumbling. That's dysarthria. Poor articulation. That's what rap is now. Y'all, I don't even understand words. That's what I honestly feel like they're actually doing on the mic. They just get near the mic and they go, yeah. Yeah. Go, yeah. And y'all like, yeah. This fella didn't even say any words. All he said was, yeah. That's the dumbest thing I've ever heard. So that's speech production. So poor speech production, it can be damage to the CNS. So it's actually from the motor area of the CNS, which remember when we showed you guys that representation of the face using the homunculus. So there are speech parts of the homunculus that can be damaged in the CNS, or it can be on the PNS. So they can have dysarthria because of Bell's palsy. It can cause that. But it causes weakness or paralysis or incoordination of the motor speech system. So poor articulation is the big thing. It's not a language disorder like aphasia. It's a articulation problems, motor execution. So there are classifications dealing with nomenclature. So these are some of the characteristics of it. It's going to be slurred or mumbled. So I showed you the video of that, slow and labored, poor voice characteristics, a lot of hoarseness. This isn't in the book. Poor intelligibility of what they're saying because it's not articulating well. Monotone, you'll find that in Parkinson's a lot, where they have a monotone. Nothing, it doesn't raise the tempo or the temperance of what's going on. It's pretty monotone. The motor finding, they'll have a weak tongue and lip movement, so that may be something you can work on therapeutically. Poor breath support, so that is definitely stuff we work on. teaching them how to breathe in before they speak out, using those muscles, poor control of pitch, and they could have drooling. You'll see that a lot with Bell's palsy, like a drool coming down the side of the mouth because they can't control it. There are 6 classifications of dysarthria. I tried to break them down into things that make sense. So this is kind of, use the slide versus the book. Spastic is an upper motor neuron lesion. Speech is going to be strained and slow. They'll also have with it hypertonicity and hyperreflexia. So it's like an upper motor neuron. Same thing you see with all upper motor neurons. Flaccid dysarthria, lower motor neuron, cranial nerve damage, breathiness, so they have to take a breath just to talk. Hypernasality, meaning they're speaking through their nose because they can't produce it well through their mouth. Atrophy and fasciculations, those are the things you see with lower motor neuron. Ataxia, anytime you see the word ataxia, what should you automatically think about? Cerebellar. If I'm ataxic, I'm all over the place, that should instantly make you think cerebellar. So it's cerebellar lesion. So they're going to have slurred, drunken quality of speech, kind of a scanning speech, but they're also going to have that poor intention, poor coordination. They're going to have ataxia, and they're going to have movement tremors. So movement tremors, not resting, but movement tremors. Then you can have hypokinetic dysarthria. This is basal ganglia. You see this with Parkinson's a lot. Low speech volume, monotone, rapidly rushing speech. They're going to have very low, soft speech. They're not going to talk fast. So LVST therapy works very good for hypokinetic. Hyperkinetic is basal ganglia. We see this with Huntington's disease. Variable pitch, harsh voice, irregular articulations, kind of all over, like billismus. Think about billismus type thing. Hemibillismus, kind of all over the place. And then it could be mixed, and that's the one that's not in the book. ALS and MS will have a mixed dysarthria. It's a combination of spastic plus flaccid for ALS, and a combination of ataxic and spastic for MS. And so those are the 6 types of dysarthria. How do we work with these patients? Diaphragmatic breathing, that's going to be the big thing. They need to learn how to use the diaphragm, so you want to teach diaphragmatic breathing. Posture, you don't want them sitting. A lot of Parkinsonian patients like this slump forward rounded posture. They'll end up in that. You want to get them back using P&F stuff, dual D2 flexion patterns to get them back and up, trying to get that posture together. Upper trunk mobility skills, getting upper thoracic extended and moving in the upper thoracic. Strengthening the breath muscles, so you can work on that through repeatedly doing it. Have them talk, at a loud tone and timing if you want to do that. Changes, be careful. If you notice any patient with a worsening of speech than they had the day before, they probably have a new stroke going on. So if they were fluently talking to you and normal on Monday, by Wednesday they're slurring and they can't say the words, you may be the first person that's picked up on they have a new stroke. And therapy a lot of times is the first group of people to pick up on this dysfunction. That's a real thing. Drooling or choking, they may have an aspiration risk. You definitely mention that to nursing. They may need to go on an aspiration diet. Speech therapy may need to be brought in. Every patient doesn't get speech therapy orders. So you may be the one that says to the supervising PT, hey, this patient is having this problem. I think they need a speech therapy order. You may be that person. Or if they have overall, increase in muscle weakness, they may have something else neurological going on, myasthenia gravis, ALS, things like that, MS type thing. Dysarthria usually follows dysphagia. notice things like coughing when they're eating, like candy or anything else, simple stuff. If they're eating popcorn, people get choked on there. Popcorn gets stuck. They're just eating stuff that shouldn't get stuck, and they're coughing all the time. That may be interesting. Wet, gurgly after swallowing. Think about that. Fatigue while eating. You want to start thinking about that. And again, dysphagia is eating function, so poor eating ability. So when you're dealing with dysphagia, again, it's dealing with the ability, or the book tells us, it's a condition in which an individual has interruption in either swallowing or maintenance of nutrition and hydration. And they usually go, dysphagia and dysarthria will usually go together. These will have to be treated by speech-language pathologists specifically. One of the things they do is called a barium swallow test. They're going to take them down, ask them to swallow a liquid that highlights like barium, and then they're going to watch the liquid. They do it with a CT, and they watch the liquid go down into the esophagus and see where it goes. And they're looking to see if it's going to go into the trachea and go into the lungs, which causes aspiration pneumonia, or is it going to go into the esophagus and go down into the stomach. And so they'll use different consistencies of liquids, like they'll do pudding, they'll do water, they'll do a thicket liquid, and they're trying to make sure the liquid goes in the right place. But all dysphagia treatments is done by speech-language pathology. The major thing for PT and PTA when you're dealing with dysphagia is watching out for NPO on the door. What does NPO stand for? Nothing by mouth. Very good. So if you see that on the door, don't allow them to eat, and don't let them con you into giving them something to eat, ever. So never let them con you into that. And then lying flat can cause people to aspirate. So keep the head of the bed elevated about 30 degrees. That helps as well. All right. That's all for chapter 28. See, I guess y'all were right. We didn't go over but another 4 minutes. Any questions? Really, I didn't go over 4 minutes. I spent 4 minutes explaining the other stuff. So I knocked it out in an hour. There you go. Somebody curious. Thank you, sir. All right. Questions, comments, concerns?
What's your last lecture?
No, gosh, no. We'll do more later. We still got stuff to do Thursday, Wednesday. Yeah, not for this class. This is the last lecture for Ther 2 ever. Yes, it is over.